Welcome everyone to today's webinar. I am Laura Bearda with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We are looking forward to hearing your questions. Today's session is being recorded and will be available after the event. In about a week following the webinar, we will send all registrants a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Scott Rifkin is the founder and executive chairman of Realtime Medical Systems, and Phyllis Watusik is executive vice president of Realtime Medical Systems. At this time, I am pleased to turn the floor over to Scott to begin today's presentation.
Hi there, this is Dr. Scott Rifkin. My goal today is to show you and explain to you how two large hospital systems managed to decrease their readmissions by 50% from nursing homes, and also to reduce the cost to their ACOs by as much as 50% also from the nursing homes. And so let me start with a little bit of my background, and that may be helpful to set where this comes from. I'm an internal medicine physician by background, a lowly internist, and when I first went into practice, I took the job, I needed some part-time work, and I took a job as a medical director for a nursing home. And it was a troubled nursing home. We got it turned around. The state of Maryland decided I was the guy that knew how to turn around troubled facilities. And so I took on about 50 assignments over the next 10 years or so, mostly in Maryland, but in Tennessee and up and down the East Coast for health departments that needed somebody to get involved in turning around troubled facilities, generally from a regulatory perspective. And so I did that for 20 or so years. And then back in 2003, I had a chance to buy a nursing center. We ended up building that entity from one nursing center and 120 beds to 21 nursing centers and 4,000 beds in Maryland and Pennsylvania. At one point, we owned a quarter of all the nursing home beds in the city of Philadelphia, about 1,200 beds. And our method of growing the company was to be the best provider from an outcome perspective in any community we were in. And so part of what you're going to hear about today was an effort within that nursing home company to create a way to reduce admissions to the hospital. And I'll talk more about that in just a few seconds. But in addition to the nursing home beds that I owned, I also have 6 Advantage plans in 6 different states that provide Medicare insurance in nursing centers. And then, Phyllis, if you would give your background for a moment.
Sure, Scott, happy to. My name is Phyllis Watusik. I'm a nurse by background. I worked in a health system in South Central Pennsylvania for 35 years. And I also had a case management background, but most recently, I was the director of Post Acute, and it was my job to put together a preferred provider network of SNFs to manage cost, readmission, and length of stay for our ACO. We found when we looked at our ACO data that our hospital costs were pretty much in line, but our post-acute costs were almost double what the national average was, and it was my role to bring those costs into line.
Thanks, Phyllis. So Phyllis's background and Phyllis was a big part of creating this program when she was a key person at Lancaster General Hospital, and that's one of the examples we'll talk about in just a minute. So what we're going to talk about, first of all, is our attempt as a nursing home provider to reduce our readmissions and be a better partner to hospitals that we worked with. And what we noticed, and this will translate into what hospitals can do to make this all happen as well. But one of the things we noticed very early on, that when we looked at our admissions back to the hospital, and not just readmissions, but any admissions. Today we care about readmissions, but we also care about admissions when we're paying for them. And in many value-based programs, we're now being asked at the hospital level to pay the cost or part of the cost of those admissions. If you have an ACO, you're paying for them, for example. So one of the things we noticed that 70% of the time, when we looked at a patient who went to the hospital, there was something in the chart that if we had noticed it a few days earlier, we might have prevented that admission. And you got to start with the fact that nursing homes and hospitals don't operate the same way. Nursing homes have predominantly a nursing aide staff. They might have one LPN on a unit, and they might have one RN for the entire building. The physicians come in once a month sometimes, and depending on the kind of patient, they may see a patient 2 or 3 days after they get admitted. So it's not the same level or ability of both nursing and medical staff that you're used to in the hospital. And so to give you an example of these 70% of patients that we might have avoided a hospitalization for, I'll give you a couple quick examples. One is the patient with a history of heart failure. Now, in the medical record system of the nursing home, there's a diagnosis of heart failure. The patient might be on Lasix, for which they have a diagnosis of heart failure. But the nursing aide taking care of that patient with a 200% turnover each year probably has never read the medical record and has no idea of this stuff. And when Mrs. Jones has swollen feet, they just write a little note in the chart, Mrs. Jones's feet are a little swollen today. They probably don't put A and B together. So that patient with a history of heart failure who now has swollen feet or developed a cough or gained 3 or 4 or 5 pounds is the same patient who ends up in your emergency room in pulmonary edema 3 days from now if we do nothing about this. For $1 worth of generic Lasix, you can prevent a $15,000 or $20,000 hospital stay if you pick this up a couple days ahead of time. Now, let me give you another example. Very common problem in nursing homes is patients who don't have a bowel movement for a couple of days. And if you don't do anything about it, they end up with an impaction and septic sitting in the emergency room. And that, again, becomes a long hospital stay with lots of morbidity and mortality. And yet, if we had treated that constipation 2 or 3 days earlier, that admission may never have happened. And so I can go through dozens of these kind of examples, but the bottom line to take out of that is very often, 60, 70% of the time, there's something in that medical record that might have made that admission not happen, okay? And just to point out from a regulatory perspective, the way nursing homes look at it, they don't get a deficiency because Mrs. Jones broke her hip. She stood up and broke her hip and fell over. What they get a deficiency for is because Mrs. Jones stood up, fell down, broke her hip, and there was something in the chart that could have prevented her from falling. You know, the note in the chart that Mrs. Jones is dizzy this morning, but nothing got done about it. Or the note in the chart that Mrs. Jones isn't eating or drinking very well the last 2 or 3 days. And again, maybe nothing got done about it because folks don't always see the outcomes of what seem like minor medical issues that they document, okay? So in any case, we went out there to our EMR provider. There's about 10 medical record providers for nursing homes. Point Click Care has 35, 40% of the market, and there's another 8 or 9 that have the rest of the market. And we went to Point Click Care, that was our EMR provider, and we said, okay, our nurses and our doctors have gotten together and come up with 300 questions we want to ask of the chart every single day. And we want to do it out of today's information, not the MDS data that you typically get at the hospital level. That MDS data fed to you by several companies. It's 30, 60, 90, even 6 months old when we get it. Now, we wanted to use the medical record data from that shift so that we would have not predictive analytics. I mean, predictive analytics is great after the fact to analyze what happened. But we wanted to find interventional data, interventional analytics. So we came up with about 300 queries, and it was everything from Mrs. Jones, which patient hasn't had a bowel movement in 2 days, to which patient has a history of heart failure and has developed a cough or swollen feet, to whose ADLs have changed, who's eating or drinking less, who's complaining of dizziness. 300 of those questions. And we went to our EMR provider who said, no problem, you can get that out of our database, just run 300 reports. And obviously that wasn't going to work. So what we did instead is we went out and hired software engineers, and they created an application that would sit on our EMR, and now any of those nursing home EMRs. and would go in and ask the simple questions that we wanted the answers to, and then take those questions and push just the positives to our charge nurses as they walked in to change a shift report. And we'll show you that report in just a second. But we ended up with this simple system to prevent us missing things in the chart. And when we did that, and we'll show you the example in a few moments, but when we did that, we dropped our readmissions from 22% down to 8% in our nursing homes. And in the city of Philadelphia, where we had just bought the 1,200 beds, they were 4- and 5-star rated buildings, but they had a 40% readmission rate. And we dropped that down to about 12%. Okay? And so, that was a huge impact, and we started to understand, what the value of that kind of data mining was, and creating an interventional analytics platform. Okay, so before I get too much more into the details of the platform, let's talk a little bit about why you all care about this, and I think you all know. Readmission penalties, BPCI advanced programs, population health programs, ACOs, and other value-based programs are all leading to you being more responsible for what goes on in the nursing homes. And if you look at your readmissions, for example, if 10% of the time the patients are being sent to a nursing home, they're 20% of your readmissions. They're the frailer, sicker patients. They're low-hanging fruit. You know where they are. They're much easier to prevent a readmission there, or an admission when it comes to your ACO, for example, or if you've got an Advantage Plan program. They're much easier to prevent that admission than to try to prevent an admission out in the community. You got a willing partner to work with access into the medical record system, okay? But I also want to talk to you a little bit about how nursing homes think, and I think it helps in this discussion. Keep this in mind. Nursing homes have cross-purpose to the hospital. For example, they like longer lengths of stay. They get paid more. So if you're an ACO sending a patient to a nursing center, they want a 30-day length of stay when the real length of stay ought to be 8 or 10 or 12 days. Okay? In some ways, nursing homes like readmissions and admissions because the patient goes to the ER and comes back Medicare eligible again. So the real way to get the nursing homes to care about your problem and not just pay lip service to it is A, to have really good data on what's going on in the nursing home, B, having some ability to look over their shoulder a bit, and C, as you create your narrow networks, which hospitals all over the country are doing to work with their nursing homes. There might be, as in Phyllis's case, when she was at Lancaster General, they picked 8 or 10 nursing centers out of double that number and said, look, if you'll work with us to reduce length of stay for our ACO, and you'll work with us to reduce readmissions, we'll encourage more patients to use your nursing centers as opposed to the nursing centers we didn't pick. And so that narrow network where a nursing home operator is being offered more volume for better outcomes, that's a home run for an operator. I operated 4,000 beds. Any nursing home operator in the world is willing to do that. And they'll jump through hoops to make you guys happy to be able to do that with you, okay? So if you say to them that we have a program in place where we're going to all work together with the data, and I'll show you that in a minute and how Phyllis helped us set that up. If you can show that to the nursing home operator, they will do that in a heartbeat, okay? So that's the kind of program we're going to talk about in just a second. Let me go to show you the report at the nursing home level that we created. And in a minute, we're going to talk about the hospital view of all this. So, Phyllis, if you would bring up the clinical alert report, please. If you've got that. Okay, and there it is. Okay, so this is the simple little report. We run those 300 queries every single shift off the data sitting in the EMR of the nursing home. And we're able to pull in the data from any nursing home and any nursing home EMR today. So if there's 6 different nursing homes with 5 different owners, and 6 different EMRs with 5 different owners, there's no integration project for the hospital to do. It's all done outside on the cloud. It's all HIPAA compliant. And we end up taking this little report and pushing it to the charge nurses. So you see the name of the patient on the left, the alert message, how much was eaten. The second one is the heart failure with cough and edema example. And then on the right are the suggested interventions from AMDA, the American Medical Directors Association, and Interact. Those are the standard protocols that every nursing home knows about today. Those are the national standard protocols. And we push that to the charge nurse. And the reason we add the protocol to it is that in nursing homes, the nurses are too busy to look at protocol books. They wing it all the time. If you can get them to follow the protocol, again, a lot of this stuff gets prevented. So this is the simple report we push to them. Phyllis, would you go to the next page, please? There you go. Okay, so before we get to this, we take that protocol, we push it to the nursing homes. We also read all the narrative notes. Go back to the previous slide, Phyllis, if you would. And we look at all the narrative notes for keywords, and we also tell the QA nurse in the nursing home anytime that any hundreds of keywords get put in the narrative notes. So if somebody writes diarrhea spelled 8 different ways, or shortness of breath with abbreviations, we know about it, we push it to the charge nurse, and they can respond to it. And they get tremendous results. So we were getting these results. We teamed up with Medline. All over the country, Medline, you probably know them. They're a big seller of healthcare products, probably the second biggest in the country. And we're in about 750 nursing homes now with this. And then Phyllis, who's on the call with us today, working for Lancaster General, which is one of the University of Pennsylvania hospitals, grabs us at a conference one day and says, all this data that you have and access into the nursing home EMR would be very interesting to me as I help manage the ACO and manage down the readmissions of my 700-bed hospital. And so we started working with Lancaster General and Phyllis to create a simple platform that the hospital didn't have to create, that they didn't have to do an integration project, that they didn't have to use any time of their IT department at all. And could we create a platform that would allow the case managers, because data without a program doesn't make any sense, but could we create a platform that Phyllis and her department could use to know what was going on in the nursing homes in real time and use it to intervene on admissions and on length of stay for the ACO? So let me walk you through this basic platform in a second. If you look at this slide, you see in the upper left corner a bar graph, and it's rehospitalization rates. So one of the things that Phyllis was able to do, and she's going to talk to you more about her program in a few moments, but one of the things she was able to do is to look at the readmission rates for every nursing home in her narrow network. And all of it being defined the same way and without having to wait 6 months or 9 months to get MDS-based data. It was today's data. You can go back 30 days. You can go back 90 days. You can go back any way, you can sort it any way you want. You can sort this data by insurance plan, by unit of the nursing home, by diagnosis, we're adding the ability to look at doctors. So you can actually tell a nursing center you're working with when they say to you, when you say to them that their readmission rate's higher than everybody else, and they say, well, we're trying, we're working hard. You can look at them and say, well, the problem is that on the weekends, when Dr. Smith is covering, your readmission rate is triple what it is the rest of the week. And the problem is that Dr. Smith, who doesn't want to get involved in what's going on in the nursing home because he's just a coverage doctor, is sending everybody to the emergency room. Or you can say, you're really having a problem with hip fracture patients, or you're really having a problem with heart failure patients or diabetics or whatever else. You're able to take this data and sort it in that way, okay? Phyllis just moved to the slide where you can actually drill down. And if you look at the bottom of the slide, you can click on any of these facilities and actually see the patients that got admitted, their length of stay, and you can even drill down to what were the alerts they were triggering when they got admitted, okay? Phyllis, if you would go back to the previous slide. In the right upper corner, you've got a bar graph that shows hospital days per 1,000 patients per year. That's the same data, but for the long-term care population of the nursing home. In the bottom left corner, you've got admissions per 1,000 members. And in the right corner, one of the things we've done, and you'll hear more about it when Phyllis talks about her program, every single patient in the nursing home gets risk stratified every single day automatically. And we use a variant of the LACE scale that you're all used to. And what we did is we took the basic idea of the LACE scale and adapted it to the differences in nursing homes. So, for example, we base things on the underlying diagnoses, how recently they've been in the hospital, how recently they've been readmitted to the hospital, and what alerts they're triggering in the nursing home. And we have 90,000 patients in the system. And those 90,000 patients, and Phyllis has brought that up on the screen. That CARD score, which is what we call it, stands for clinical alerts, admission recency, readmissions, and diagnoses. That CARD score correlates directly to the risk of readmission. So what Phyllis was able to do with this scoring of each patient, she was able to use her case managers to look at those high-risk patients every day, intervene and discuss with the nursing home, and she'll talk more about this in a second, and have a huge impact, and she'll talk about the impact. I don't want to steal her thunder. But we can actually give the case, instead of trying to look at every patient every day, the case managers can look at the 5 people in the nursing home, much more likely to come back. And they only see the patients you sent them. You don't see, because of HIPAA, we're very careful with that, you don't see the patients that anybody else sent to that nursing home, okay? And Phyllis, if you would go back, actually stay where you are then. So one of the things Phyllis just brought up on the screen is the points that are assigned under that CARD scale or that LACE scale equivalent. And again, it adds up to a certain number of points, and enough points in their high risk. And a lower number of points, they're medium risk, and they can be low risk. But Phyllis, if you would go back to the Product HS screen, please. Going back one more there. Okay, one more. There we go. Okay, the other thing you're able to do with this, when you say to a nursing home, you know, all of our nursing homes are running at readmission rates of 18%, but you're running at 30%. You always get the same answer. And the answer you get is, we have sicker patients, or we take sicker patients. And occasionally that's true, but it's usually not. It's usually kind of bull. And with this tool, you're able to look at the nursing center and see the relative acuity, essentially the accumulation of all those CARD scores, and see the relative acuity of a nursing center. And again, you can sort this by diagnosis, by insurer, by any length of time, and it's immediate data. You're not looking at it a year later. You're looking at last month. If today you look back 30 days, you could see the real 30 days from today back. You're not looking at January or May of last year. And you can say to them, you know, your acuity isn't really higher than the others. You should be running a readmission number about the same as the others, or you can agree with them, depending on what the data shows. But you have it at your fingertips. Okay, so Phyllis, if you would go back forward a couple slides, please. Keep going, keep going, keep going. There you go. Okay, so in a moment, I'm going to hand this off to Phyllis. And Phyllis will talk about the program she helped us design for Lancaster General. And then she'll also talk about the University of Maryland Medical Center and their downtown campus. Phyllis's hospital, and she'll tell you more about it, 700-ish beds, suburban and rural, and the University of Maryland Medical Center is an inner-city academic medical center. So somewhat different facilities. But the bottom line was the same, and she'll show you the results. And the 50% drop we're talking about applies to both of them. And what we were able to do is to create a simple platform that didn't take very much work for the health systems. They could bring it up within 30 to 90 days. They didn't have to get their IT people involved. We didn't pull any data out of the Epic or Cerner systems. And we were able to give them direct real-time access into the nursing homes and the patients that they had responsibility for. So Phyllis, if you want to take this over and talk about the program at Lancaster General, and then the program that you installed at the University of Maryland Medical Center, and then the outcomes from that.
Sure. Thank you, Scott. So while we talk a little bit about those programs, I just want to review the platform that we're talking about. So we're getting data directly out of the SNF EHR, and the IT team, both on the SNF side and the hospital side, really does not have to do a lot of work. What we're getting is interventional moments we can really impact the patient's course of care by finding those key nuggets that are buried in EMRs so that we can act upon them and prevent bad things from happening. We talked a little about risk scoring and the CARD score. We look at ADL functions so you can kind of track how your patient is progressing through their skilled stay. We look at quality metrics, keywords, clinical analysis, and of course, most importantly, those live readmission rates, because I know that's what a lot of hospitals care about. So as you build your post-acute network, what you're really trying to do is have a quality focus using data. So you're data-driven. You want to know who does the best with what case type, and you want to look at outcomes. You know, what are length of stay outcomes? What are quality outcomes? What are readmission outcomes? All of those kind of things are what you're basing your network on and what you're trying to achieve by having a preferred provider network. So that was my focus when I built the program. And as you begin to put your network together and narrow it down, the things we all look for in our network is we want those high-performing SNFs. The SNFs that really bring quality. They have a high quality rating from the STARS program, from CMS. We want them to manage their length of stay to what our standards are. We really want those patient outcomes that we talked a little bit about. And of course, we want low readmission rates. What we get is typically very different than what we want. We get very unclear data that doesn't necessarily make sense to us. And it doesn't come from a system we feel is valid at times. It can be old. And then we get some of those excuses that we talked about a little bit earlier with Scott saying, you know, my readmission rate is higher because you sent me sicker patients. Well, there was no way to prove that or understand if that was really happening. And then each facility had their own metrics to measure their success by. And there wasn't an easy way to look across your network and understand how everybody was performing kind of at a one glance piece. And so I always found it very difficult to compare the SNFs in my network. And one of the things that I really liked about Realtime is that the data we didn't have to argue about. It wasn't their data, my data, his data, CMS data, claims data. It was data that came directly out of the SNF EMR. So the SNF couldn't argue about it because that was their data. The important piece was that myself and my case managers were seeing that as it was happening. And it gave us that opportunity to really be able to impact patients at that level at that time. So it was really live. We didn't have to integrate anything with the hospital EMR because we were an Epic shop. And so that was often difficult. And we saw the same data. So that was really important to me because then we could begin to have conversations and build things off of the same thing that we were seeing. So that was helpful. I want to talk about how we built the program. So obviously the live data was very important, but we built around that data. It's not just the data itself, it's how you use the data. So obviously I only had 2 case managers. We could not manage every patient that was discharged to a SNF in our community. So we needed a risk adjustment tool, and building the CARD score using LACE, which I understood as a hospital provider, was really important in focusing the resources we had to manage the most at-risk patients. And that's a pretty common principle in case management. It was also really important to identify who we needed to talk to at the SNF. So it wasn't, you know, we didn't just call and talk to whoever happened to be there that day. We worked on setting up really important communication structures there so that we would get responses within hours, not within days. And then we talked about what our readmissions looked like. So it was really easy to grab that readmission data out of Realtime, and we sat down as a group, not just as individual SNFs, and talked about our readmissions. Now, we obviously didn't use patient names, but we did describe cases, and we understood we had kind of group learning. So if this happened in one SNF, it was likely to happen in another. And so as a group, we learned about managing care together and protocols and deploying that across a system network. The standards of care, once we understood what was happening, we could address what those standards are. And I'll use CHF as an example. So when our cardiologists would discharge CHF patients to home, they gave them what was called a rescue diuretic program. Well, we never did that with SNFs, but in a SNF, you can really manage that better because you have all the data available and you have somebody else managing the medication. So we put clinical standards in place under those suggested interventions when a clinical alert came up, and we were able to standardize care across our network, and that really improved outcomes because what was supposed to happen was the patient was right there in the platform, easy for everybody to see, and we could say, hey, did you do that? Did you give them the extra dose of diuretic? And if they didn't, why not? And then we need to talk about that. We also know that when you're transitioning a patient from a higher level of care, like an acute care hospital, to a SNF, there's always a higher risk of readmission in that first 72 hours. So we always looked at those patients as they kind of came into the system and assisted with those transitions, making sure that the med list was correct, knowing if they needed a wound vac or any other type of equipment so that patients weren't readmitted quickly because the facility didn't have what they need to take care of the patient. And that's as on the hospital side as much as on the SNF side. And then we held each other accountable in both directions. So there were times when it was a hospital error and we admitted that and we looked at our systems and tried to fix that. But there were times when it was a SNF issue and we worked together to fix that as well. So we really looked at it as we were partners in this patient's care. And what we put on the table every time was what is the right thing to do for the patient, and that's what should drive our decision making. So I'm going to talk about the first case study. This is the hospital that I actually worked at. We have almost 700 beds and about 35,000 discharges per year, and we averaged anywhere from 3,000 to 4,000 hospital to SNF discharges. And then when we looked at our ACO early on, as I mentioned in my introduction, our SNF and post-acute care costs were almost double the national average. And so that was obviously very concerning to us because we were in a low-cost area, and we saw inordinate length of stays on these SNF patients. So I want to talk a little bit about readmission rates. When we started in 2016, our readmission rate with our preferred network was right around 18%. And actually, at that time, that wasn't bad because typically you would see readmission rates across the country of 25 to 30% from SNFs. So already we felt we were doing well. And I wasn't sure exactly how much we would be able to impact the readmission rate, but it was really dramatic. We dropped about 50%, a little more. So we went in our first performance year down to 8.5%, and we were able to maintain that in the next fiscal year. And actually, fiscal year 19 is ending, and I just talked to them, and they're at about 8.3%. So the thing that really makes this, I think, relatable across many networks is that you can sustain the results. Having that data, building the conversation, having those relationships really leads to improved patient care because we all know it's a really bad thing for patients to have to be readmitted to the hospital. And it does happen, and you'll never get to zero. But your goal is always to get as low as you can because that's what helps the patients and what's most important for them. So really great results. Yeah.
Phyllis, would you comment for a moment on the amount of staff? And I think you did, but I think it's important to understand that it didn't take you a huge amount of staff, and it didn't take you a huge amount of effort to get there. I mean, there's been a lot that goes into it, but talk about the amount of staff and the amount of time it took to create that program.
Yeah, sure, Scott. That's a very good point. So I only had 2 case managers, and they were, we pulled them out of another case management program that we had because we knew we had to put some resources towards that. But they were repurposed in our organization to focus primarily on post-acute. So it was 2 case managers, it wasn't a lot, and they were able to access the data on a daily basis and then have those conversations with those clinicians on the other side. And sometimes we had a problem on the hospital side where our physicians were not answering the questions that the SNF had about a patient. They would call a specialist, not get a response for 3 days, and the patient would end up back in the hospital. So we facilitated that communication when there were communication issues. So it really didn't take a lot of staff, and we saw a dramatic improvement in about 3 to 6 months. We saw a lot of decline in readmission. So not a lot.
And your IT people, and just to say it again, your IT people didn't have to get involved in this.
No, they did not. In fact, the only thing they did do is they allowed us to get single sign-on. So Realtime does have a single sign-on. They take pass-through credentials from Epic. And so it made it even easier for my staff to just go into Epic, and Realtime would launch for them as well. So really easy from the IT perspective. And now I just want to talk a little bit more about length of stay and clinical standard results. So our ACO, as I told you, had a high cost of post-acute care, and it was related to length of stay because obviously the longer the patient is in, the more the costs are. In that first performance year in 2017, we dropped SNF days or utilization by 43%. So we almost cut in half the number of SNF days we had. And that was done by focusing on length of stay, which is another area you can see in real time. We looked at fractured hip and CHF patients, and we put plans of care or clinical pathways into place, outlining what should happen on day 1 or day 2, along with clinical alerts that drove process. So if the patient wasn't rehabbing, I got an alert, and I understood that they were having a lot of pain, and we had to manage a pain plan for that patient to get back on track and rehab. So we were really able to manage length of stay by doing that, and that resulted in $4 million reduction in post-acute SNF spend.
So to jump in for 1 second, keep in mind, I mentioned this earlier, nursing homes, I owned 4,000 nursing home beds. We love to stretch out length of stay. We really do. And as nursing home operators, we're pretty good at it and how to justify it. But when you're able to look in the chart and see what their ADLs are and see that Mrs. Jones is walking 100 feet or 200 feet or whatever the standard is for that hip fracture, that hip replacement that she had, and ask the simple question, well, why isn't Mrs. Smith going home? And making sure that things are happening in the order that they should happen, the nursing homes will come around because, again, they want to be in your network. They want you to think they do a great job. And now that you got real data, they know that they've got to perform to a certain level to stay in that network. And that'll drive down the length of stay. Is that a fair statement, Phyllis?
Absolutely, Scott. They want to work together with you, and they have to get out of their mindset that they are managing these patients towards their bottom line and instead manage to what the patient outcomes are. So that's been very helpful. And then next, I want to talk a little bit about the Baltimore Academic Medical Center we talked about. So these are 2 hospitals in downtown Baltimore. They have about 33,000 discharges. Their average SNF readmission rate was 28% in their preferred market. And that's really important because Maryland is a waiver state, which is a total cost of care. So every readmission costs them real dollars. They don't get it back.
Yeah, actually, right. To explain that waiver a little further, Maryland hospitals get a global budget. And they actually don't want to just prevent readmissions. They want to prevent every admission. They get almost the same budget whether they admit 1,000 patients or 10 patients. And so they're now very involved in working out in the community to prevent any admissions. So this was particularly significant in a waivered Medicare state. And CMS is looking at doing this in other states now as well. When Maryland went to this, they dropped the admission rate to hospitals by about 12%. And the hospitals were okay with it because they're on a set budget. Okay, so I'll turn this back over to you, Phyllis, to show the results.
Yeah, sure. So as I said, if you look on the far right, the average readmit rate for this network was about 28%. And in 6 months, it dropped to 17%. So if you look across all of the facilities that are listed there, some went from 25% to 0. Most of them really dropped. The D one, that is a vent and dialysis unit, and we are starting to make some additional strides with them, but at the 6-month mark, they had only dropped, a little bit in readmission, but a dramatic change in what they saw with the readmission.
Right. And let me point out one other thing on this. So this represents whatever number, 8 or 9 nursing homes. Except for the one vent and dialysis unit, if you take that outlier out of it, they actually dropped down to about 13% from 28%, which is really pretty remarkable. And they did that in under 6 months, and we've got HIE data that confirms it as well. So Phyllis, I'm sorry, I didn't mean to jump in, but go ahead.
No, that's okay. So really great results. It's about using the data to drive results. So having both sides of the street, acute and post-acute, looking at the same data and collaborating on patient care is really what drives the results. But you can't do that if you don't have the data to start with. And so I think that's one of the important features of what the entire program is. We could have done all of those other things, and we did. We had case management in place prior to utilizing Realtime. We had some clinical plans and protocols, but we could never understand or kind of see into what was really happening at the SNF. And when you're not looking and you can't see, things happen that you don't necessarily want to, or there's not a conversation about why you did this, took care of the patient this way, or didn't call us when you first saw that they were gaining weight and when there was a little edema. And so it just brings both sides together to focus on what the right thing for the patient to do is. So right. I think, Scott, you have any other further comments?
Yeah, one of the things that seems to work very well with this is if all we do is we go to, and I've sat on the board of a major health system and the such, where this was always a topic. And if all we do is go to the nursing centers and say, we're creating this network of nursing centers, there's sure going to be winners and losers, and we want you to perform better, but if we don't give them a tool that allows them to perform better, then it doesn't really work in the long run. To just say, oh, you got to get your readmission rates down. But if we don't have the data to really follow it, if all we're using is old MDS data, or billing data, which is typically what hospitals have, then the nursing homes, A, know you don't have any real good data, and B, they feel kind of helpless that they don't have a way to actually do what you want them to do. So the idea is to give them a workable platform that pushes down admissions, which is what the base product did before it was ever used for hospitals, and then give the health system the ability to oversee it all and put their case management ability into effect. And that's where you get these dramatic drops in pretty quick order out of health systems that do this. So I think that's the sort of the take-home lesson here. And Phyllis, I assume we have some questions. Do you want to go to those?
Yeah.
Or did you have something else you wanted to say first?
No, I think we can go ahead and go to questions. Laura, do you have any questions for us?
Yes, and thank you, Scott and Phyllis, for that fantastic presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for. We do have a few questions rolling in, so we'll jump right in here. First, Phyllis and Scott, what kind of IT support does the product need on the SNF and hospital side?
Okay, so on the hospital side, it needs virtually nothing. and the reason for that is we do not pull or put data into your Epic or Cerner or other hospital system. We're only going into the nursing home EMRs. So you think of it, and we're not a nursing home EMR, we're an application, just like an app that sits on your iPhone. It's an application that sits on top of the nursing home EMR. We've already worked out the integration of that data with every one of those nursing home EMR systems. And so without having to do an integration project that if a hospital did, they'd spend, 2 years and millions of bucks getting there. You can just plug into this. You have to ask your nursing homes to participate. And in our experience, if you ask the nursing homes to participate, they all want to be in your network and they all say yes. And the cost to them is, $400, $500, $600 a month. It's almost nothing. So they're always willing to participate. And so there's really no IT lifting at all. Somebody is going to want to look at the HIPAA qualifications and be comfortable with that. And we've had dozens of health systems now look at that and be comfortable with it. But other than that, there's nothing really for the IT department to do. Phyllis, anything you want to say on that?
No, it is really easy. And because it's not integrated, your IT department really doesn't have to do anything.
It allows you to go up with a system, with a program within 90 days. You really can get up very quickly. Do we have another question, Laura?
Yes, I do. We do have another attendee who would like to know, why do SNFs want to use this product? How does it help them? And do SNFs have to document in your platform?
Very interesting. Okay, first of all, before we ever had hospital systems we worked with, we had SNF folks who used this. There's over 700 SNFs under contract, really in the last year and a half or so, 2 years. And they use it for lots of reasons. A, they want to make their health systems happy. B, they want to prevent regulatory trouble. One G-level deficiency, which is a high-level deficiency in a nursing home, can end up costing them $1 million, in lost admissions because they had to go on an admissions ban, in legal costs and fines from CMS. So they want to prevent those costs. And third, there are plenty of operators who really do want to do a quality job of care. And they know that lower readmissions and lower admissions in general are a direct corollary for the quality of care. So there are plenty of organizations who do it for that reason. So that's A. B, when I was doing this as an inside project for our nursing homes, my chief clinical officer, this wonderful woman who'd been a director of nursing, both at the hospital and nursing home level, and came to me and said, Scott, this is a great project. It's really neat. It's going to be good for the patients, but you can't create 1 minute of extra work for my nurses. They're already overwhelmed. So all we did was pull data they were already putting into the EMR. So they don't put it in our system. They just use their EMR the way they've always used their EMR. We just pull data out of it. And what's interesting is, one of the questions you ask, well, how good is the data in the EMR? Well, one of the things we realized very quickly is as soon as people started using that data and looking over the shoulder of the staff a little bit, the quality of the input of the data got much better. And I'll give you a great example. Our system is going to tell you or tell the nursing home if Mrs. Jones hasn't had a bowel movement in 3 days. Well, the charge nurse then goes to the nursing aide and says, Mrs. Jones didn't have a bowel movement in 3 days. Is that the case? And the nursing aide is going to do one of two things. Say, yeah, I don't think she has. Or B, say, well, she did, but we didn't document it. The minute that interaction occurs, that nursing aide is going to start documenting the bowel movements. Because that charge nurse is going to say, well, you got to document that. Why didn't you? And I'm going to come to you anytime that a patient doesn't have it documented. So you get some false positives in the beginning, but what you really get after about a week is much better documentation. So it ends up that the nursing homes use the software, they find the benefits of it, the implementation gets better, and it's not any extra work for the nursing homes, so they don't mind doing it. Any other comments on that, Phyllis, or we'll move on to the next question?
No, I think you covered it.
Good.
Yes, sir.
Laura, what do you got next?
Absolutely. The next question we have here is, what case management resources does this require from the hospital?
Phyllis, that one's yours.
Okay, thanks, Scott. So it really doesn't take a lot. As I told you, we had about 35,000 discharges at the hospital I worked at, and 3,000 to 4,000 of those were SNFs. And so the case management principle of just managing those high-risk patients really led us to use 2 case managers over 10 facilities. So they each had 5 facilities. They were able to manage all those high-risk patients in there and assist with other care transition issues, even if the patient wasn't a high-risk patient. And that really worked well, and we certainly had enough coverage, and were able to really get those dramatic results that we showed in reduction of readmission and reduction of length of stay. And I think, as Scott mentioned earlier, the fact that you're looking at this and you can have an intelligent conversation around the data is what really drives those results. So not a lot of resources.
Good.
Great. Thank you so much for clarifying that. Oh, yep. Did you want to add anything to that, Scott?
No. I'm fine, Laura. I would never presume to know more about case management than Phyllis.
Excellent. All right, we'll jump right into the next question here. Another attendee would like to know, can this be integrated into a hospital EMR?
I'm sorry, ask that question again, please.
Sure. Can this be integrated into a hospital EMR?
Okay, so there is single sign-on with the EMR, with the hospital EMRs. We purposely don't integrate into the data of the hospital EMR. And the reason for that is now you've got a whole integration project and all kinds of other HIPAA questions, and it's just a difficult process. And it's not necessary for the impact that we're trying to have. Now, I will tell you that one of the 2 major hospital EMR systems has offered to do that with us and at least put them up directly on the platform. And we will do that at some point and make that an option. But at this point, you just don't have to do that if you don't want to, and we don't actually encourage it.
Okay, great. Thank you for clarifying that. The next question I have here is, do you have a single sign-on?
We do. And Phyllis, you may want to, you used at Lancaster General. Do you want to walk through that?
Yeah. So typically, and the reason we do this is because as people change positions and leave roles, the hospital IT system is really good at managing who gets access to what. And so when case managers leave or go into another role, they change their restrictions around what data they can access. And so when we do single sign-on, that puts it back in the IT people's hands of making sure that only the right people have access to the data. So that's really the purpose behind single sign-on. It's also really ease of use for the case manager, so that once they sign into their EMR, whatever EMR that is, Realtime can also launch based on those requirements from the sign-on. So it makes it very easy to use.
Very good.
Great. That's helpful to understand. Yeah.
Mm-hmm. Oh. What else you got?
Absolutely. The next question we have here is, how is this product a win-win-win for the hospital, SNF, and the patient?
Gotcha. Okay, so let me put on my former nursing home operator hat, okay? The biggest fear I have as an operator, the biggest fear, is that the health system that is in my market, or several health systems in my market, create narrow networks and don't include me. Because what they're hearing at their national conferences is that there's going to be winners and losers, and the winners are going to be the facilities that have lots of Medicare lives, lots of Medicare patients coming from the hospital. And the losers in their world are going to be the facilities that really only depend on Medicaid patients to maintain their economics. And they realize that if they want to be in that narrow network down the road, they have to be a better partner on outcomes now for hospitals. You know, the savvier operators get that, particularly the small and medium operators. The big chains have been in such economic trouble, and most of them have gone either bankrupt or been sold or broken up. You've got 1 or 2 that are sort of just hanging on by their, by the white knuckles on a ledge. But the medium and small operators, they really understand that they need to be in that preferred network. And so they're willing to and able to implement these kind of programs where they're looking at the data from the system in real time and really trying to have those better outcomes. And if you give them a tool to get there, they will gladly trade off shorter length of stay for higher volume of admissions. There's a new payment system coming in for nursing homes that's going to make that draw to them even stronger. It's called PDPM. And that's going to emphasize payments in the first few days and a much lower payment as the patient is in the nursing center, and encourage them to get people home sooner. So all of this is sort of dovetailing together, and the smarter operators know that it's a win for them if it's a win for the hospital systems. So hopefully that answered that question.
Yes, that was a great point. And we do have a ton of questions here, so I'll move on to the next one. Does your system do predictive analytics?
You know, that's an interesting question. Yes and no. We really don't do predictive analytics. Is great when you got nothing better, and it really implies that you're looking at large populations. What we want to do is interventional analytics. We want to find that moment in time that if we intervene on Monday, that the patient doesn't get admitted on Thursday. I mean, we can certainly give the hospital all the predictive analytics they've been getting from some of the companies that look at MDS data and run that same predictive work based on real-time data. So it's just better and newer data with the same kind of predictive analytics. And that's in the modules. We didn't go through all that today. But the real strength of this is that you get past the predictive analytics. You stop telling people, well, 6 months ago or a year ago, you didn't do very well with heart failure patients in your nursing home. And you change to, you have 3 heart failure patients in your nursing home today that if you do A, B, C, or D, they're less likely to get admitted to the hospital. So that's a real step up from, you know, just noticing something after the fact and not being sure why, to here's why we're having a problem, let's intervene, so that when we look at that data 6 months from now, it looks great. So I think that's the answer to the question. Yes, you can have predictive analytics, but you really want interventional analytics. Laura, what else?
Great.
What other questions
yeah.
you got?
Well, the next question I have here is for Phyllis. It's asking, are the SNFs and Phyllis examples owned by the hospital or health system? And if not, how did the hospital obtain real-time access to the EMR?
So thanks, Laura. No, we did not own those SNFs. They were partners, and we had an agreement with them about being in our network. And part of that agreement was that they would utilize real-time and we would have access to the data. Of course, as we're responsible for readmissions, we have a right to help manage that patient once they leave the hospital. So that's an ACO thing. It's also certainly a hospital readmission reduction program piece. We do have a BAA signed with those, and we only ever saw the patients that had a relationship to us, that were either discharged from our hospital, managed by our primary care patients, or managed by SNFs that we own that were in the facility. So we only saw patients, again, that directly related back to us.
And the University of Maryland sent out a letter and asked for volunteer facilities, and virtually all the buildings they worked with volunteered to do it. Again, they just want to make the health system happy and be in that network. You know, the cost of this to them is less than 1 admission a year. Okay, Laura, what else? What other questions?
Yes, and we have time for one more question here. Where does the software reside, on the hospital's EMR, or is it on the SNF's EMR, and how does the integration work if the hospital and the SNF are on different EMRs?
Okay, so it resides in the cloud. I am far from being an IT person or a software engineer, but we're happy to, if anybody's got the specific questions, is have our software engineers talk to them directly or to their IT folks. It all sits up in the cloud, which is run by Realtime. It is not integrated into your EMR at all. It just doesn't work that way, and on purpose. We don't want to create a minute of delay at the level of the hospital IT department. Phyllis, any comments on that?
No, I think you hit on it, Scott.
Okay.
Perfect.
Okay, Laura.
Well, Scott or Phyllis, do you have any? Yeah, do you have any final thoughts?
No, other than we're thrilled to talk to anybody who has any questions about this. Our email addresses are on the screen as we speak. I know you'll be getting a copy of this. It's an interesting program, and it really does deliver what we've claimed. I mean, with Phyllis's help when she was at Lancaster General, we figured out a program that dropped admissions in half and ACO costs in half, and we're happy to stand behind that and take risk along with you all and make programs work. So at your convenience, drop us an email or contact us, through our website. Anything else, Phyllis?
No, I think that's it. I think that the important piece about this is you can't do anything without having data, and this product gives you data that you can really work with your partners on the post-acute side.
Thanks so much, everybody.
Great. Yeah, thank you. I want to thank Scott and Phyllis for their excellent presentation and Real-Time Medical Systems for sponsoring today's webinar. Enjoy the rest of your day, and we will look forward to having you join us for future webinars.